Nurse.org and Major League Sports teams are honoring nurses with discounted game tickets and once-in-a-lifetime experiences. From throwing the first pitch to riding the Zamboni to on-court recognition, join the fun. Visit nurse.org/nurse night to find a nurse appreciation event near you and grab your discounted tickets today.
The Love and Leary Podcast is where nursing leadership, innovation, and real talk come together. Hosted by nurse leaders Marion Leary
and Rebecca Love.
The show dives into the issues that matter most to today's nursing community.
Each episode features candid conversations, expert insights, and bold perspectives on healthcare, leadership, advocacy, and the future of nursing. Whether you're a clinical nurse, nurse leader, or another healthcare changemaker, Love and Leary offers thoughtful dialogue and practical takeaways to inform, inspire, and empower nurses at every stage of our careers.
Hello, Rebecca. How's it going?
Good to see you, Marion. Excited to be here.
I know. This is our first episode now with Nurse.org, Love and Leary Podcast. And I couldn't be more excited to be joined today by Jerilyn Hoover, who I met on, of course, LinkedIn. You know, she reached out to me. It was sort of during the height of all of the DOGE and the Trump administration's efficiency happenings last year. And we were able to connect on LinkedIn, and her story really stuck out to me. So, Jerilyn, I'm really excited for you to be on the Love and Leary podcast and to talk about your story, because I think it's so important for people to understand the personal and professional impact that has been going on for now what will be almost a year into the Trump administration.
Well, thank you so much for having me. I'm really happy to be here with you both today talking about everything that has happened in the last year and kind of possible new directions for where things could be going and how that interacts with nursing. So I can share a little bit about me. I am a public health nurse by background. I knew when I was in nursing school that I was really interested in public health because everyone I kept seeing in the hospital, I realized that we were in the hospital getting them better to send them back to the same environments that brought them to the hospital in the first place. And so that's what got me really interested in public health in the beginning. And then I had grown up outside of the US, so I had a really global oriented perspective to what I wanted to do with nursing. And so I worked as a nurse in Haiti for a while, and then I came back to the US and I wanted to work in a primary healthcare setting. So I worked at a community health center, an FQHC here in the US as a nurse care manager for several years. And I learned just a whole other side of what healthcare looks like in the US and gained a real appreciation for all of the ways that people fall through the cracks in our healthcare system here and how hard we make it for people to just get what they need from a health system and for health workers to do the parts of their jobs that they enjoy. I can't tell you the number of times I sat there with my phone, like I had a corded phone in my nursing office, and I just was on the phone with insurance companies all the time trying to get needed medications covered for my patients. And I just wanted to like bang it against the wall and say, this is important. This matters for them. And you're making it harder. You're making it harder for them to do what they need for their health.
We could have a whole other episode, and we will have a whole other episode on how our health systems make it impossible for people to care and to provide care. But anyway, continue.
So I wanted to not just be a nurse who was really frustrated for my whole career and super cynical and like withdrawn about how hard everything was. So I knew I needed more skills and a different type of skill set to combine with my nursing experience and background. So I did a master's in public health, focused in health systems and policy issues at Johns Hopkins. And it was during my studies at Hopkins that I started getting really interested in the intersection between healthcare and public health programs, and specifically health workforce issues. So recognizing that the healthcare workforce is what powers health. We don't have health without healthcare workers. We don't have health without nurses in particular. And that's true the world over, although the challenges vary depending on which country you're in. So I did some global work during my MPH. And then after I got my first job with the U.S. Agency for International Development, and I have to tell you, it felt like such a stretch because my first job title was as a data analyst. And I remember thinking, they know I'm a nurse, right? Like, why do they want to hire me in this data analyst role? But it was data about the healthcare workers that were being supported through USAID's global health programs. And I took the leap. I was at USAID in the end for 5 years in a variety of different roles. Started out as a contractor, and then I was a civil servant with USAID for the last 4 years until the agency was closed last year. I was a health workforce development advisor and the acting health workforce branch chief, where I led on strategy for the health workforce investments and health systems strengthening investments that were related to health workers that we made through USAID's global health programs before the agency was closed last year.
So I have a ton of questions, but before that, can you sort of talk about that day? And did you know it was coming? What was it like there to, be told you're no longer relevant?
Yeah. So the week of inauguration, which we're nearing the 1 year anniversary of, the week of inauguration, I was in Ivory Coast. I was meeting with nursing associations in the country to talk about what would have been a new project where we were helping them to kind of overhaul the nursing curriculum in the country and put in place some new professional development programs for nurses, because there still to this day is no continuing professional development program for nurses or other health workers that is required or provided in the country. So I was there having these incredible meetings and conversations about, what the needs were, ways that they thought the funding they were going to receive would be able to help. And then at the end, I was getting all of these updates in the evenings, seeing what was happening, seeing the new executive orders, and just having all sorts of side chat with our teams about, what the ramifications would be of these things. And then I would just remember Friday night, I was on my way home back to the US, and I saw the news about the executive order putting the 90-day freeze on all the aid freeze. And I remember just being on a flight back to the US and having tears rolling down my face as I thought about the implications for what had just happened and what that was going to mean for people. I had just met with nurses that day who were going to find out on Monday that they couldn't keep doing the program that they had been doing. So I worked on the PEPFAR program, which is the HIV program that was started in the early 2000s under the Bush administration. That program has saved over 20 million lives while the program has been running. It's done incredible work, and they supported hundreds of thousands of health workers, over 300,000 health workers, many of whom were community health workers, nurses, laboratory specialists, pharmacists, other health workers. And a lot of those people lost their jobs overnight when the USAID freezes hit, because what that meant was that partners who had USAID money, even if they had the money already, were not allowed to spend anything. So overnight, they were told you cannot expend any further money. That means they had to lay off people with basically no notice. And so people that had been supported by these programs for decades, in some cases, health workers who had been doing work supported through these programs for decades, were then told overnight that not only are you not able to do your job anymore because we can't pay you, but all of these community members that you have spent so many years helping with accessing HIV medications or screening their children for malaria, you have to stop doing that overnight, and you have to watch your community members show up to clinics that have closed doors and gates that are locked and a sign that says they can't see people right now because the funds were cut off overnight. And then in short order, within the next few weeks, they put in place what was supposed to be a waiver process for humanitarian aid and life-saving assistance. So a life-saving waiver is what they called it. And that was supposed to include things like HIV medications for pregnant women and things like that. But they put that in place, but then they didn't actually have the processes to give money to people that they needed to do those services. So on paper, you're allowed to provide services under a waiver, but the implementation of that was so spotty that still many people were not able to access the medications they needed. There were really well done articles by Nicholas Kristof where he went to a number of countries and interviewed doctors and nurses about the impact of this. And in one case, I believe it was in Ghana, he talked to a number of nurses, and they were saying that they had, I think it was only enough they had only enough HIV medication for 1 in 4 of the pregnant women with HIV that they were meant to be treating. And when they asked they asked their nurse supervisor what they were supposed to do, and he said, pray that USAID comes back. So we put health workers in this morally injurious situation because of how quickly what happened was rolled out. I think there were lots of ways that this could have been done that could have taken a more stepwise approach or said, okay, after 2 months or 6 months or a certain amount of time or a certain amount of funds, that they would put pauses on amounts. But the way that it happened so quickly overnight left so many people in a lurch, left partner governments in a lurch that the US had partnered with for decades in many cases. They didn't have the supply chains in place to have, they didn't have orders advanced of many of these medications that they needed. So it put health workers in this impossible situation of, if they did have a job, which many did not, if they did have a job, they didn't have medications because the supply chains that had been supported by USAID and other development partners had been so interrupted.
I mean, it's just so incredibly heart-wrenching and infuriating. I think it's really important for people to understand we're talking about hundreds of thousands of federal employees who lost their jobs. And, you recently published an article in the American Nurse with some colleagues, which we'll reference. I'll put a link below in a minute, but I want to read just one part of it that to quantify for people what we're talking about here, right? So you say in this article that these cuts ended decades-long partnerships to strengthen health systems around the globe, improve maternal-child health, counter HIV, as you've just been talking about, malaria, tuberculosis. These cuts ended CDC public health programs, especially for community health centers who relied on those funds. And then that's not even to talk about the NIH and how nurse-led research has been suspended and research in other programs have been suspended and what all that means for the health of our patients and communities. Like, these are hugely impactful programs that individuals who've worked there were affected by, but locally and globally, patients and communities are affected by. And I think it's really important that people understand the ramifications of what has occurred and what is occurring and what will occur.
Absolutely. And I think there's implications at multiple levels, of course. There's the end human cost of the loss of life that has happened as a result of how this has been done. There are good sources out there, including the impact counter from Boston University and a Lancet article that came out this last year, estimating that last year, over 700,000 people died as a result of these aid cuts that would not have died, and that 2/3 of them were children. 2/3 of those 700,000 people who died were children. And the Lancet article estimates 14 million additional avoidable deaths by 2030. That's 700,000 children a year, it's estimating, will die because of what has happened. And I think we're in this really hard place right now of, 2025 was kind of the year of undoing. It was a year of catastrophic disruption at levels none had anticipated. And we're still in this space where we're waiting to see what comes next. And I believe strongly that there will be new things that arise out of the ashes of what has happened this last year, but we can't quite see those things yet. So I'm hopeful that there will be new efforts and partnerships and initiatives to help address some of these things in new ways that we could never have thought about before, because, we had structures in place previously that worked on some of those issues, imperfect as they were. So I'm hopeful that there will be new things that come out of this, but we're still in this space of waiting and watching to see what happens. So there's the human impact of it, kind of the end human impact. Then on the health workers themselves who had their work totally disrupted, we got reports of health workers that committed suicide because they had found out overnight that not only had they lost their jobs, and many of them were the sole breadwinner, not only for their immediate family, but also for their extended families. So they lost their jobs overnight. And then many of them, I think the ramifications of knowing that their community members were going to go without care that they had worked personally to make sure they got for so long are just really weighty. And it sits particularly heavy with me because, my health, through my health workforce and health system strengthening work, we talked all the time about positive working environments and trying to make sure that people had, safe staffing and that they were supported with the best evidence that they needed to do their jobs well. So the fact that how quickly things were done, that we were directly responsible for such harm to so many people and disruption to their lives sits very heavily.
Hey nurses, looking for exclusive discounts? Nurse.org has you covered with deals on everything. Save big on the essentials you need to excel in your career. Don't miss out. Visit nurse.org/discounts for the latest discounts made just for you.
You know, Jerilyn, you said something very interesting, which 2025 was the year of the undoing. 700,000 preventable deaths. People died because of the undoing and the vacuum now that exists in this space, and the impact of that globally on the millions of lives that are going to be perish in the course of the next 4 years because of the actions that have unfolded here. And I think that this, for us as nurses, is a devastating reality, that one that we did not have a tremendous amount of line of sight into, or the impact. And even further into your paper, you discuss elements of this that we were aware of the human impact, I think in an abstract kind of way, what these programs would mean. But I don't think we understood the impact to nursing as well as to what these cuts were going to do with the cuts to NNIR funding, the cuts to NIH. And I think, could you tell us a little bit about the things that are happening in that space?
Absolutely. So the premise of the article that you'll share with the audiences as well is that I think an unintended consequence of the cuts this last year that a lot of people, especially within the nursing profession, I'm not hearing talk about, is that the federal government, through its agencies directly, through its programs that it funded at the national and state level, and through the research that it enabled, the federal government was a significant supporter and enabler of nursing career pathways beyond the bedside. So, i.e., if you were not working clinically and you were not working in academia, many nursing career pathways and jobs were either directly or indirectly supported by the federal government. I don't think people recognize that because, there's been all these articles about civil servants getting cut and the federal government and government workers. And there've been so many articles about that. I think what a lot of people don't recognize is that's also nurses. There were I'm a nurse. There were nurses working at USAID. There were nurses working at CDC that lost their jobs, dozens of them.
Your article where you list out the roles that nurses do within the federal government that some of them I didn't know either. I think it's really important to highlight that today on this podcast, but I think more broadly, I don't think the general public understand the impact nurses have and had in these types of roles and in these types of organizations. And, I'm so glad that you included that in the article and bringing light to that, because I think, again, we know that most people think nurses are are just at the bedside in a hospital or healthcare organization, but the scope and versatility of what we do is so much more.
And Jerilyn and to emphasize what Marion's saying, and you should go into this, the impact of these cuts just eliminated some of the top echelons of nurse scientists and researchers in the world who had major influence overseeing policy and driving influence in ways that we see in no other parts of the federal government. We basically removed an entire population and profession from the entire federal government leadership in a way that is now going to leave an absence of nursing voices to influence any forms of policy that we have at scale. And to me, what that means, and where Marion and I have spent much of our careers, how do we elevate, amplify, and change the trajectory for nurses to step into non-traditional roles? And I think your paper so beautifully eloquates and explains that by the removal and cutting of these programs, we've wiped out an entire generation of progress by nurses to lead in spaces where before they have been limited from access. And I think, Jerilyn, if you could give us just, Marion had you tell the story of what happened that day. You told us the impact on the front lines across healthcare and all these other countries and the health workers down to that. But what I would love to understand from you is, what was that environment like inside of your organizations with nursing leaders? How were they able to engage? And now, knowing that they are removed, what are the vacuums or the concerns that you have for the impacts of that, not only on the professional government, but also for the profession of nursing?
Yeah, that's a great question. I think one thing I'd start with is that, I told you that my first job title at USAID was as a data analyst, and then afterwards as a health workforce development advisor. There's no nurse anywhere in those job titles. I didn't have to be a nurse to do those jobs, but I think you and I believe your audience would also agree, we want nurses in jobs where decisions are being made about how health services are designed and how public health programs are implemented. I can't tell you the number of times that I would, have conversations with people about some, health program, and they would say, oh, it's just not happening the exact, the way that we thought it would. We did this intervention, and then this thing that we anticipated is not what we're seeing. And I would often ask, well, have you talked to some of the nurses that are delivering the services or delivering the intervention that you're asking them to? Because 9 times out of 10, they'll be able to give you a laundry list of reasons why what you thought was going to happen is not either feasible in the environment clinically, or because there are so many other pressures on the patient populations they're working with. And it's nurses that have the ground level knowledge to know that and to be able to tell you that. And so I've always thought of my role working in non-nursing spaces as a bit of a translator and a bridge between the world of nursing and the world of public health programs, to be able to help get those things to talk to each other, recognize the values and strengths that each brings, and to be able to be a voice for the nursing workforce and the profession in spaces outside of our own professional domains. And what we emphasize in the article as well is that we say in our own definitions of nursing and in what particularly public health nursing leadership looks like, it says it includes policy, it includes program development and strategy and all of these things. But in practice, we don't have hardly any support for nurses who want to chart paths in those areas. And so I think there have been and still are really incredible nurses who have charted non-traditional careers in, whether it was directly in federal government employment or in public health program work. But often people didn't refer to themselves as nurses. Like, they might not even have had the word nurse in their profile, because either in some settings, it could be seen as a professional liability almost. What we have to be conscious of, by losing all of the people that we've lost in the last year from the roles that they were in, if we don't figure out a way as a profession to expand and find new avenues for influence in some of those spaces, what we are losing is we're narrowing our own definition of what we say nursing leadership is. We are retrenching into only clinical or academic spaces, and then saying, but why aren't you listening to us? Why aren't you taking our voice? But if we're not in the spaces outside of those clinical or academic avenues, then there's just less of us to be near the door to be able to jump into a conversation when it's meaningful. So I think those are some of the real challenges that we're facing right now.
Couldn't 1,000% agree more. So, what are some calls to action that you think we need to be doing right now?
A couple things we outline in the paper as well, and I'm happy to share more. If you look up the LinkedIn post that I made about the article, it includes some specific resources for nurses that have been impacted. So, and our article outlines actions that people can take at the individual level, or kind of the nurse level. Nurses get engaged in policy action. There's the RN Shift Change event that's going to be happening in DC this spring. People can join that. People can find ways to get engaged with their state nursing associations and advocacy issues, or with ANA directly, and other national associations representing the profession in different ways. So there's the advocacy piece of it. There's the kind of direct mentorship and support. I found it hugely valuable this last year to connect with a number of nursing leaders, yourself, Marion, included, across the U.S., to talk about directions, talk about where you see nursing leadership in the U.S. and globally, and spaces to engage. So there were so many things that came out of the conversations that I had with nursing leaders. And I was really struck by how many nurse leaders in the U.S. feel really concerned by what they see happening to the profession, and they want to help, but they aren't sure where to plug in and where to engage. I think having some sort of more concerted mentoring program or effort between senior nurse leaders, in some cases retired nurse leaders who have more time that they would like to give, partnerships between nurses like that and nurses who have lost positions or been displaced from work that they were doing this year is really helpful, because I think there's a big skills translation issue, which we outline in the paper, that people that have developed these really deep skill sets in areas that are kind of hard to talk about in like standard healthcare language in the US. And so as people try to find roles that best use their expertise. I think there is a translation gap there that a lot of nurse leaders are experiencing right now. And then at the association level, I think having more targeted support for nurses that have been displaced this last year would be really useful. I think I know a lot of people who've pivoted back to clinical practice, and as many nurses know, the cost of renewing your licenses and getting up to date on things often comes out of your own pocket. And that certainly has been the case for a lot of people I've known this year. So any additional kind of learning resources and support, I think, would be useful.
Well, Jerilyn, we appreciate you joining us on this time. I think the truth is not many of us were aware of the impact across to the scale that you were, the roles of nurses that have been disrupted by this, and also the current state of where they are and how they're trying to navigate new time and finding locations for which they can use their expertise to do things. I think the one thing is that we found always in nursing is that we can constantly redevelop and also amplify and change over time. We've seen the profession of nursing morph with the changes of winds and policy. This one feels different, but I hope and I believe many of us, and why we're so excited that you were our guest on our episode with Nurse.org, was because there was an instant moment of time that the recognition that nursing is doing and the impact it has globally to the community, but also the impact to the profession here at home, is one that is being felt uniquely at a time that we must be addressing everything that is happening with a critical lens, and then also lend our support and our voice so that the silence does not swamp what otherwise could be replaced with positive action moving forward. So we're thrilled to have you, Marion. I'll turn it over to you.
Yeah, I'll just say thank you so much for sharing your story. I know it's not always easy to put yourself out there like that, but it's, to Rebecca's point, it's really important and impactful that we understand the devastation that some of these policies are having locally, globally, individually as a profession, and putting faces and stories to those things are hopefully going to help push for better change. To your point, I think we all need to connect. So follow Jerilyn on LinkedIn, follow us on LinkedIn. There is a community of nurses and individuals who want to push back against what policy changes are happening that do not benefit our patients, our communities, and those of us in this country. So we'll continue to keep speaking out and speaking up and promoting all the good work that folks are doing.
Thanks. And I know myself and the co-authors that I wrote the article with, we're hoping this will be the start of more conversation and engagement about this issue. So we would welcome people reaching out with ideas and look forward to being in touch.
Thank you so much.
Thanks for listening to the Love and Leary Podcast. We hope this conversation sparked new ideas, challenged your thinking, and reminded you of the power nurses have to lead change.
If you enjoyed this episode, be sure to subscribe, leave a review, and share it. You can find more episodes and join the conversation wherever you do your podcast listening.